Well, see, there's three of them right there. Ladies, can you hear me?
Yeah.
Yep.
Okay, great. Hannah should be joining us at some point in time, so. Okay, so there's Sophia.
Depends on the heat, like, yeah, like 10 and below. Yeah, I was freaking out. I was like, I have no food. The DC is closed.
Oh, it's closed today.
It closed at 6. I didn't go to practice until 6:30. And so I was like, well, yeah.
How remarkably unfortunate.
Open normal hours.
Yes, they should.
But it wasn't. I walked up there, the doors were shut. Maybe it was an accident. And there was a posted sign. I was like, no, please, I'm hungry. I know. No, it's okay, Jack. I've done it before too, and looking at it, catch it really glad you delete snap. So that I like, because I'll like go to send screens or something, or like snap somebody, but then it will pop up in the nursing group, like the nursing group tab pop up. I'm like, no, send a picture of the nursing group tab.
All right, well, that was the best. Did you guys get the handouts?
Yeah.
Yes, you need to have them with you. That's why it said in the email for tonight.
Probably on my computer.
Yeah, on your computer, that's fine. That's fine. I hope you guys had a great Easter. I hope you celebrated the resurrection of our Lord with gusto. And I hope you were safe on the roads. For our colleagues who are still on the roads, we pray for their safe arrival back here. And for the rest of us, we pray that we wake up to be able to learn tonight. We are talking about hypertension. There are lots of other things that can cause hypertension. The biggie, of course, is going to be kidney diseases. So can various types of heart diseases.
Boarding in progress.
Was that my computer that said that? Yeah?
Yeah.
Okay, well, it is recording. Thank you, computer. So kidney diseases, the big one usually will be nephrotic syndromes. There are a whole bunch of these, but they symptomatically are all pretty similar. You start out with a period where you really start to have large amounts of volume that's lost. You have a lot of protein that's lost. And then after a while, the kidney, the glomerular Bowman's capsule boundary just gets so scarred up that you really don't produce a lot of urine. You either need dialysis or you need a kidney transplant. So nephrotic syndromes, of course, will raise blood pressure substantially. Heart diseases, especially cardiomyopathies, can raise blood pressure substantially. Anytime you have an enlargement of the heart, anything also that interferes with blood vessels. So blood pressure really is a product, two different physiological features. One is cardiac output. So that does not mean Colorado, that means cardiac output. The other is systemic vascular resistance. So cardiac output, that's going to be in beats per minute. That's how fast your heart is beating. And systemic vascular resistance, that's going to be essentially the resistance, which is usually measured in ohms in electricity per beat. So it has to do with a certain amount of pressure. So it has to do with the torque, usually the millimeters of mercury per beat per unit time. This is all going to come out, believe it or not, once you do the units, to millimeters of mercury, which is torque. And that means that if your blood pressure is high, there are two ways, physiologically speaking, to lower it. One is you decrease cardiac output. You slow the heart rate. Secondly, you decrease systemic vascular resistance. Usually that means you dilate the vessels. Now, I hope this makes some intuitive sense to you, because blood pressure has to do with the collisions of the blood as it goes through vessels. Those collisions with the vessel, that creates the pressure. So the more volume you have in the vessel, the blood pressure is going to be higher. Likewise, the smaller the diameter of the vessel, the more collisions you're going to have. That's going to create higher pressure. If you vasodilate, or if you reduce blood volume, you will decrease systemic vascular resistance. So either one of those, if you reduce them, you will reduce blood pressure. So mathematically, I know some of you are allergic to math, but we'll just do the one phrase here. Cardiac output and systemic vascular resistance are directly proportional to blood pressure. Meaning, they go up, blood pressure goes up. They go down, blood pressure goes down. So antihypertensives will attack this problem either at the cardiac output level or at the systemic vascular resistance level, or some drugs will actually attack it at both. And if you have high blood pressure, of course, it can really do a number on several target organs: your heart, your brain, your retina, your kidneys, and peripheral vessels and things like that. Things that are really bad for your vessels, of course, are smoking, obesity, physical inactivity, high blood lipids, diabetes mellitus, and so on and so forth, and blah, blah, blah. Okay, we've talked about a lot of that. I'm going to move on. JNC7 is a very long-standing body of research. It's been published several times. It's still ongoing. This involves tens of thousands, even hundreds of thousands of people who've been looked at, and data have been collected. And the old JNC7 numbers, based on this extensive amount of research, that is, what is a healthy blood pressure? What lowers your risk of cardiovascular accidents? They said that stage 1 hypertension was 140, between 140 and 159. Anything above 160 was stage 2, And normal was anywhere between 120 and about 139. That's now been lowered again, based on continuing research. Now it's anything above 130. Anything above 130 is stage 1. So 120 to 130 is prehypertension. Anything from 130 to about 150, that's stage 1. Anything above 150 is stage 2 hypertension. And so these are the new standards again, based on continuing research. The drug companies didn't get together and collude with the FDA and say, we want to make more money off antihypertensives, so let's make it so people have to take them at lower and lower blood pressures. If you're cynical, you might think that. And given the case with certain research projects, yeah, you might not be forgiven for thinking that, but that was not the case here, because Janssen 7 was not sponsored by industry. It's an industry independent research project, very, very well constructed, ongoing, lots of data. That's where this comes from. And if you have a systolic blood pressure over 180 or a diastolic blood pressure above 120, that's a hypertensive crisis. If there's any signs of end organ damage, one of the first places you'll easily see it is in the eyes usually. You'll start to see clipping, what's called clipping in the vessels of the eye. You can use an ophthalmoscope to see that. Instead of seeing regular retinal vessels, they'll be clipped, they'll be really small. And that's evidence essentially of end organ damage in the retina. You'll need to treat that blood pressure aggressively. So here are the arrows in our antihypertensive quiver. They are diuretics. Diuretics, you might know them by another term, water pill. Water pill. Paige, what do water pills do?
I've heard.
Give me your best guess. Well, they actually dehydrate you. They make your body produce more water in the form of fill in the blank. We're all adults here. Urine, thank you. They make you pee. Okay, they increase the amount of filtrate released by the kidney. So they decrease blood volume. Because they decrease blood volume, they'll decrease systemic vascular resistance. So those are your diuretics. Then there are the beta blockers. Beta blockers are going to attack the problem here. Cardiac output, they'll decrease cardiac output. They slow the heart rate down. Then you have a very widely used group of drugs, the ACE inhibitors. They're going to inhibit the renin, angiotensin, aldosterone pathway. By inhibiting this pathway, they will drop blood pressure very effectively. And then a closely related group of drugs that work similarly, the angiotensin II receptor blockers. These two are almost spoken about in the same breath because where they inhibit hypertension is at a similar place. So they're going to prevent vasoconstriction. They're going to reduce systemic vascular resistance. And then the calcium channel blockers. These, we'll see these again when we get to heart medicines, but these, the group that we're going to talk about, they will cause vasodilation and they will decrease systemic vascular resistance. These other drugs will not be used as much. They'll be used under special conditions. And we'll talk about them as we have time. So, first group we're going to talk about are the beta blockers. So we need to refresh our memory as to where various beta and alpha adrenergic receptors are found. So in the heart, it's largely beta 1 adrenergic receptors. When those are activated by epinephrine or norepinephrine, they increase the heart rate and they increase the force of contraction. Beta blockers will antagonize beta-1 receptors. They'll bind them, they'll prevent epinephrine or norepinephrine from binding to them. Therefore, they will slow the heart rate down. By slowing the heart rate down, they will decrease cardiac output. By decreasing cardiac output, they will decrease blood pressure. Make sense? You also have another isotype of beta receptors elsewhere. You have beta-2 receptors. You have those in various arterioles, like those that service the skeletal muscles and the liver and a few other places too. They're also found in the smooth muscle that surrounds the vascular tree. And they're also, the beta-1s are also in the kidney. And they will, when stimulated, will cause a release of renin. So some of these beta blockers will be pretty specific for beta-1 receptors. Some of them will not be specific. They will tend to bind beta-1 and beta-2 receptors roughly equally. So there will be two groups of beta blockers. And if you get the beta blocker handout out, you will see these two groups of beta blockers include the cardioselective and the non-cardioselective beta blockers. Cardioselective beta blockers are relatively specific for the beta-1 receptor. Non-cardioselective beta blockers are not very selective for the beta-1 receptors. They will tend to bind and antagonize both beta-1 and beta-2 receptors. Those are the two main groups of beta blockers. So beta blockers, they inhibit sympathetic stimulation of the heart. They antagonize beta-1 receptors. A few of them are partial agonists. Partial agonists, drawing way from the beginning of the class. Partial agonists. They bind to the receptor. They don't activate it completely. They activate it a little bit. So you get a little bit of stimulation from the receptor, but not nearly as much as the native ligand would give you. Therefore, they won't reduce the heart rate quite as much as some of the others. So with beta blockers, you get a reduced heart rate. Excuse me. You get a reduced force of heart contraction. You get reduced cardiac output, reduced blood pressure, and reduced renin production. Because you get reduced renin production, you'll get a little bit of vasodilation. So beta blockers, even though their main bailiwick is reducing cardiac output, they'll also reduce systemic vascular resistance a bit as well. So look with me, please, at this handout. Here's a little mnemonic for you. You ready? Cardioselective beta blockers start with A through M. So atenolol, bisoprolol, metoprolol, any of those, they are cardioselective. And you'll see the one that doesn't fit is the bibolol, which is a weirdo. But all the others essentially are cardioselective. Now, if any of you want to work emergency or ICU, esmolol is used a lot because it's available in an IV form and it works really fast. And it's a short half-life. So this is your go-to drug in the ICU or the ED if someone's heart is just really taken off. Use esmolol. So that gets used a lot. The other drug I want to underline is labetalol. Labetalol. Labetalol is the drug of choice for hypertension during pregnancy. It is safe during pregnancy. And I just found out earlier this year, one of the go-to drugs for hypertension during pregnancy, methyl-dopa is no longer manufactured in this country. It's been discontinued. So learn something every day. Because it was not discontinued at the beginning of the semester. It's just been discontinued.
The one that's.
Labetalol is the one that's used in pregnancy. So those drugs that have intrinsic sympathomimetic activity, that is, they are partial agonists, include these three at the bottom here. There's acebutolol. Acebutolol is cardioselective, but it's a partial agonist. So it activates the beta-1 receptor a little bit. Indolol is non-cardioselective, but it is also partial agonist. And cartiolol, which we saw before, because that is used mainly for glaucoma. So is timolol. Timolol also is non-cardioselective, but it's used mainly for glaucoma. It's not usually used for blood pressure. Notice these drugs end in LOL. Laughing out loud. So remember, high blood pressure is no laughing matter. LOL. Beta blockers are laughing at your hypertension. Yes, Janelle, I know it's stupid. You look at him as if to say, I can't believe I'm sitting here with this child. Hey, if it helps you remember it, help you remember it. If a drug ends in LOL, it is a beta blocker. We're going to see that for a couple of other drugs in this group. Are we clear on beta blockers so far? They have several different side effects. So in the liver, there are beta-2 adrenergic receptors. The beta-2 adrenergic receptors, when activated, will cause more glucose to be released into the blood. There are also beta-2 receptors on the pancreatic islets. When they're activated, they promote the release of glucagon, which helps raise the blood glucose level. So if you block these beta-2 receptors, that can mess with your blood sugar. So it not only can affect glucose levels, but if you've ever known type 1 diabetic whose blood sugar gets really low, one of the first signs they get is tachycardia. Beta blockers will mask that hypoglycemia-induced tachycardia. For this reason, beta blockers, if they're used at all, have to be used with tremendous caution in diabetics because it messes with blood sugar and it will mask hypoglycemia-induced tachycardia. Second side effect, and this is really common, bradycardia. Particularly when the patient first gets on this drug. It will take them about a week to 2 weeks to get used to the drug. When they first get on it, they'll be as tired as heck. They'll be really fatigued. Now, something you should know about beta blockers. You never stop with beta blocker cold turkey because you get reflex tachycardia. So the sympathetic nerves in response to the beta blocker start making more norepinephrine. And that will take that initial bradycardia and it'll bring it up to something a little more tolerable. But it's not uncommon. Once people get on a beta blocker to have a resting heart rate of 50. That's not that uncommon. So, oh, I'm really tired, I need to stop taking this. No. Never get off a beta blocker without your doctor's permission. You should always be stepped off a beta blocker. So you tell the patient, write this down, never stop taking this medication without your doctor's permission. And if you need to be switched, you need to be stepped off it. If you stop taking a cold turkey, you can have rebound hypertension that can be really, really damaging to your body. This is serious. Dizziness, that's more first dose effect that tends to wear off. Now, there are patients who don't tolerate beta blockers. Typically, if you're on the medicine for about 4 weeks and you're still just dead dog tired and your heart rate's still in the cellar and you're still getting up and practically falling down, you're probably not beta blocker tolerant. There are some patients like that, but they need to give the drug at least 2 weeks. 1.5 to 2 weeks. Bronchospasm. This is a side effect of the non-cardioselective beta blockers. Not so much the cardioselective beta blocker. It also will depend on how hyperreactive your bronchioles are. So if you have asthma, beta blockers might, even a cardioselective beta blocker, might set you off. So beta blockers need to be used cautiously in asthmatics, and only cardioselective beta blockers should be used in that. Number 4, beta-2 receptors stimulate an enzyme found on the surfaces of cells that line the capillary walls called lipoprotein lipase. Lipoprotein lipase breaks down circulating fats that are found in lipoprotein particles. Because of the inhibition of that beta-2 receptor, beta blockers, even cardioselective ones, can raise triglyceride levels, can decrease HDL levels, and can raise LDL levels. How much do they do this? It depends. Depends on the beta blocker, depends on the patient. So that's something that needs to be watched. The patient should probably come in after the first few months of being on it, and they should get a lipid panel done. So you have the lipid panel essentially from their initial physical. And if you don't, they should get a physical and get one, or you should just do one right then and there. Then you should see how much this drug is messing with their lipids. Now, even though beta blockers are used a lot in patients with heart failure, in some types of heart failure, they can make the heart failure worse. This is particularly the case with certain types of diastolic heart failure, which we'll talk about a little bit later. Exercise intolerance, again, that tends to be first dose. As they exercise while on the medication, they tend to get over that. Usually to exercise, you need to get your heart rate up. It'll take them longer to get their heart rate up, so there'll be an initial exercise intolerance. Once they get over that, once their sympathetic nervous system kicks in, they'll be fine. Impotence is really common. Really common. Some people also report sleep disturbance. So if someone reports sleep disturbance, don't just push them off. That has been observed. So what are they good for? After someone's had a heart attack, they have to go on a beta blocker. Because the heart is damaged and it slows down, the sympathetic nervous system starts making more norepinephrine. That can turn the walls of the heart into a moth-eaten garment. Beta blockers are cardioprotective. So once you've had a heart attack, you go on a beta blocker. They're used a lot also for congestive heart failure. There is one beta blocker in particular, propranolol, the one on top here, that's used for essential tremors. It's very effective for essential tremors. That's either essential tremors that are inherited, or it could be drug-induced tremors, like, for example, lithium-induced tremors. Propranolol is very effective for that. Beta blockers are extremely effective in the case of thyroid storms caused by hyperthyroidism. Hyperthyroidism can cause tachycardia, and it can cause atrial fibrillation. Beta blockers can prevent that. Remember, atrial fibrillation can cause you to throw clots. That's dangerous. That's dangerous. So beta blockers can prevent that. Angina pectoris, when you have a clogged artery and you have a mismatch between the oxygen demand of the myocardium and the oxygen delivery to the myocardium, such that you get this crushing chest pain. That's called angina pectoris. Beta blockers are very good at treating that because they renormalize the mismatch between cardiac oxygen demand and cardiac oxygen delivery. Supraventricular tachycardias, beta blockers are quite good at that because they delay conduction. They slow down the conduction system. Perioperative hypertension, if you have someone who has an operation in this condition, it's causing them hypertension, you need to get it down before the surgery. Beta blockers can do that, and they're also used, particularly propranolol is used to treat migraine headaches. And is used prophylactically to treat migraine headaches. Very effective for many patients. There are two beta blockers that also have alpha-1 blockade. One of them is labetalol. Labetalol is used in hypertensive emergencies and for pregnancy. Carvedilol, this is one that goes by the trade name Coreg. Carvedilol is used a good deal in heart failure. So it vasodilates and it decreases preload and afterload. So it does a very good job preventing remodeling of the heart during heart failure. So notice essentially N all the way to Z is non-cardio selective. You have to kind of take labetalol and carvedilol kind of out of the equation, but A to M is cardio selective. Anything N to Z is non-cardio selective. Remember, these are also used ocularly for glaucoma. They get used for lots of things. Any questions about beta blockers? Ooh, 10. All right, we have 10 people here. So we can pair up. Here's what you're going to do. Whoever name in the alphabet is closer to A, you will start. The other person to be a patient who's had a beta blocker, that's been put on a beta blocker, you're going to give them a spiel as to how they should take it, what they should expect. And then after I hit the timer, you're going to trade, and the other one's going to give the spiel. And if you don't remember something or you say something wrong, feel free to correct each other. But go ahead, pair up. Okay, go ahead.
You're gonna, you're never gonna stop thinking unless you ask me. What you can expect. Don't take it too much.
Those of you online, go ahead and rehearse in your head what you'd say to a patient.
You have to give it 2 weeks before. You have to give it 2 weeks. You might be, like, yeah, you could have some sleep disturbances, Like, I was like trying to say implant, I was like, that's not what that is, and I know it's not. Well, you know, my wife and I are trying. Yeah. I think that's it. Yeah, you're gonna be tired, you might have some digestion.
Okay, switch roles.
Oh, I think that's not really. So it's really important. No.
Okay, stop. Okay, do you guys feel like you know a little better now what to say to a patient? Notice the impotence one. It's going to depend if you're talking to a guy or a gal, because the impotence is erectile dysfunction. So what if it's a younger patient? He says, but we want to have kids. What do you say? We have a pill for that. We have a pill for that. So you don't need to shoot down their hope. Okay. We have a pill for that. So now, if it's a woman, it's not really going to affect a woman very much. A woman can still conceive perfectly fine on a beta blocker. It's the, excuse the expression, delivery system. That's the problem in the guys with the beta blocker. All right. Now, this handout is what you'll need for the next one. Diuretics. There's 4 main types of diuretics that are listed here. Really, practically speaking, for blood pressure, you're only going to use 3 of them. And those are the thiazide diuretics, the loop diuretics, and the potassium-sparing diuretics. The carbonic anhydrase inhibitors are really not used for blood pressure so much. They are used for high altitude sickness. They're not used for blood pressure. So these work in the kidney. The thiazide diuretics work in the distal convoluted tubule. In the distal convoluted tubule, there's a sodium chloride cotransporter, and thiazide diuretics block. They gum up, they inhibit that sodium chloride cotransporter. because they leave all that salt in the filtrate, more water stays in the filtrate. So you lose more salt and you lose more water. Loop diuretics work in the thick ascending segment of the loop of Henle. You might remember the thick ascending segment of the loop of Henle is impermeable to water, but there's an extremely powerful ion that pumps sodium and chloride and potassium from the filtrate. That pump is inhibited by the loop diuretics. Because it works in the loop of Henle, they are called loop diuretics. These are definitely the most powerful of the diuretics. You lose a lot of water on these. The potassium-sparing diuretics come in two flavors. These will work in the late distal convoluted tubule and the collecting duct. One group of them antagonize the receptor for the steroid hormone aldosterone. So they are aldosterone receptor antagonists. They prevent aldosterone from working. Remember, aldosterone causes you to reabsorb sodium at the expense of potassium. You absorb sodium and you get rid of potassium. So these will cause you to peak potassium. The other group of the potassium-sparing diuretics block the channels through which potassium is going to exit into the filtrate from the cells. So whether by hook or by crook, whether by antagonizing aldosterone or gumming up channels, you spare potassium. And because you don't put potassium into the filtrate, you will end up keeping more water in the filtrate. These are among the weakest of the diuretics. They're usually used in combination with other diuretics to prevent the excessive loss of potassium because, as you might guess, one of the big side effects of these drugs is dehydration and hypokalemia, because you tend to lose a respectable amount of potassium. You lose more water, you lose more salt. You decrease blood volume, you decrease systemic vascular resistance, you drop blood pressure. The beauty of these drugs is that many of these drugs are dirt cheap. They're dirt cheap, so you can give them to people who don't have insurance. Some of these drugs literally are a month's supply is, well, here, let me just, I can tell you right here, I've got it right here. Hydrochlorothiazide is a thiazide diuretic. A month's supply of that drug, 25 to 50 milligrams once per day, is $1.10 for a month's supply of drug. Very inexpensive. Let me give you a really expensive one. Metolazone, month supply is $65. Okay, $1.10 is a lot cheaper than 65, but 65 is usually not going to break the bank. So these drugs, and that's like the most expensive of these drugs. These drugs are very inexpensive. Furosemide, which is a loop diuretic, a month supply. You take that twice a day. Month supply is $1.20. Very, very inexpensive. That's why these drugs get used a lot, because they work well and they're very inexpensive. So thiazides, notice that they either end in thiazide So chlorothiazide, hydrochlorothiazide, or metolazone, chlorthalidone, or indapamide. Metolazone seems to be a better drug for people who have impaired renal function. So that drug is usually the drug of choice if you want to use a thiazide, but your patient has bad kidneys. Chlorthalidone and indapamide have a longer half-life, and they tend to give you better reduction in blood pressure. Hydrochlorothiazide gets used a lot, again, because it's very, very inexpensive. Loop diuretics, there's 4 of them. Furosemide is the granddaddy of this group. This drug goes by the trade name of Lasix, and this can help you remember. It's called Lasix because it lasts 6 hours. Has a 6-hour half-life. It lasts 6. So furosemide, what's the half-life? 6, lasts 6 hours. That's how it got its name. Even though this drug is in a generic, many nurses in hospitals and doctors' offices will still call it Lasix because that's the thing that they know it by, even though the product they're giving to people is furosemide. Bumetanide, or Bumex, is the more powerful loop diuretic, more expensive. Dorzolamide is one of the newer ones, also very powerful. And then ethacrynic acid. This drug is important because 3 of those loop diuretics have sulfur in them. Can you take them if you have a sulfur allergy? No. Ethacrynic acid is the one that does not have sulfur in it. So, here's a quiz question I give you. Which of these is the most powerful diuretic? A, chlorothiazide. B, amiloride. C, acetazolamide. D, ethacrynic acid. What's the answer? Ethacrynic acid, because the loop diuretics are the most powerful diuretics. You lose the most water and salt on loop diuretics. Potassium-sparing diuretics. Spironolactone gets used a lot because it's very inexpensive. Spironolactone, and the other drug that's not listed there, I don't know why, is eplerenone. Eplerenone. Both eplerenone and spironolactone are aldosterone receptor antagonists. They antagonize the activity of aldosterone. They bind to the aldosterone receptor and gum it up. They're antagonists. Triamterene or amiloride inhibit the potassium channel. They inhibit the potassium channel. They bind to the channel and they gum it up. So those are your potassium-sparing diuretics. Those get used a lot in heart failure because they have very good evidence base for reducing mortality and hospitalization in people with heart failure. So if any of you end up being cardiac nurses or even ICU nurses, you'll deal with people who have heart failure. You'll see a lot of spironolactone, triamterene, that sort of thing. Carbonic anhydrase inhibitors, acetazolamide is the drug of choice. If any of you go hiking in Colorado and you go too high too fast and you start kicking your guts out, Mountain Rescue will come and they will give you some acetazolamide. That's high altitude sickness. That happened to my daughter. My sister took her hiking in Colorado, took her from about 5,000 feet to about 10,000 feet within a matter of a day. Rachel was a trooper, and then she got to the cabin and then ate a lot of chocolate and started puking. So Mountain rescue guys got in their helicopter, came out, landed. Put Rachel on a stretcher, gave her an IV. There was acetazolamide in the IV, gave her fluids. And she was fine. My sister felt just terrible. Rachel came back just talking about how much fun she had. I said, "Good. You had to have an IV jammed in." He said, "Oh, it's okay." She said, "These guys came out, they were nice. They weren't too, they didn't laugh at me or anything like that or whatever. So she had fun." So again, these work in the kidney. And to reiterate, loop diuretics work in the loop of Henle. Potassium sparing diuretics work in the late distal convoluted tubule and in the collecting tubule. Thiazide diuretics work in the DCT. I didn't mention it, but the carbonic anhydrase inhibitors work in the proximal convoluted tubule. These drugs are particularly good if someone has edema. Stephanie, what's edema mean? Loss of blood? No, that's edema. Right. Well, you got lots of extra fluid somewhere, you want to get rid of it? Diuretics are your man. Or person, or whatever. Say you have really high intracranial pressure. So you need to try to get rid of a lot of fluid relatively quickly. Diuretics. Great job. Patient's got heart failure. Their ankles are swelling. Want to get rid of that extra fluid? Diuretics. They're great at that. Really, really great at that. And they're good for blood pressure as well. Don't worry, Catherine, I'll finish this and we'll take a break. So, side effect, big one. Underline, write this down, underline it several times, dehydration. Your patient has to increase their liquid intake. Depending on the dose, depending on the diuretic they're taking, you might even want them to double it. Now, if they have heart failure, they're on volume restriction in the first place. They need to be careful how much they take in, but they still are going to need to increase their fluid intake because they know there's a lot of liquid on diuretics. Practical thing about diuretics: do not take a diuretic before you go to bed. Anybody guess why? Yes, you'll be up several times in the night going to the bathroom. You won't be able to sleep. When do you tell them to take the diuretic? When they wake up. When they wake up. So dehydration, make sure they take it when they wake up. 2, electrolyte disturbances, and these can be big. The big one, because you don't have much swing, is potassium. Potassium level. What's your leeway with potassium level? What's serum potassium? What's normal serum potassium? I'll give you a hint. 3. No. 3 milliequivalents per liter, between 3 and, or you could be low end, what's the high end? 5.5. Close. That's not much leeway, is there? You have a lot more leeway with sodium. A lot more leeway with sodium. So potassium is the one they're going to have to adjust for. So the patient must eat potassium-rich foods. Okay, potassium-rich foods. Starting here, go.
Bananas.
Potatoes, good source, good source. Great, but okay, I'll go with you. Olivia? Oh, great source of potassium. Paige? Yeah. Yeah, spinach. Spinach, good source. Jennifer?
They took literally all the good ones, I don't know. Drive through.
Very good. Particularly avocado. Other dried fruits good too. Dried fruit, very good source of potassium. Broccoli, if you eat it raw, the thing is you boil broccoli, so you kind of lose some. Yeah, that's it. Tomatoes, they're not great. Okay. I think someone else said avocado, but avocado is a very good source of potassium. Yeah. Certain types of squashes, yeah. Yeah, zucchini not so much. Butternut squash. Yeah, very good source of potassium. So here's your assignment. Okay, you listening? You're gonna get online, you're gonna make a list of 10 potassium-rich foods. You're gonna hand it in, I'm gonna give you extra credit for each one you write down. Okay? This is I really want you to do this assignment. But I want you to be able to say, you're gonna need to eat potassium-rich foods. Here's an example of some. I want you to have these at your fingertips. Instead of going, oh, well, banana, well, not sure, what else? Beans, especially white beans. Very good source of potassium. Guys, to get that online, potassium-rich foods, 10 of them, for 10 points. This is a one-time offer.
Email or paper?
Either or. Other electrolytes to watch: calcium, sodium, magnesium. Magnesium and calcium are going to kind of go together. So those are worth watching. Thiazide diuretics tend to raise calcium levels. Loop diuretics tend to lose it. So be careful. Okay, second, hyperglycemia. Sugar levels will go up on these. So will lipids. Sugar and lipids will go up. How much do they go up? Depends on the dose, depends on the patient, but they will go up. Hypotension, orthostasis, this tends to be first dose. So you tell the patient, dangle your legs before you get up. As you get up slowly, holding on to things, and then let go and walk. But if you feel dizzy, grab onto something else. If you need help, don't be afraid to ask for help, especially first dose. Photosensitivity is particularly the case with thiazide diuretic. You're going to tell your patient to wear sunscreen. They should be wearing sunscreen anyway, but particularly the case with thiazides. Ototoxicity is with loop diuretics. If the patient gets ringing in the ear, tinnitus, they probably should get off the drug. Maybe call the doctor, call the provider, and they should get off the drug. Also, these drugs should be avoided in people with gout. They increase uric acid levels in the blood. They can precipitate a gout attack. Patient doesn't have gout, it's not an issue. But these will tend to increase uric acid levels. So don't use if patient has gout. Diuretics are not safe during pregnancy. They cause volume depletion. That's a time you don't want volume depletion. Also, breastfeeding, they deplete volume. Do you want volume depleted when you're trying to make milk? No, you want the baby to do the volume depletion, not the drug. So they are not to be given during pregnancy or during breastfeeding. We'll talk about these. We're late with our break. Let's go ahead and take our break and then we'll come back. So 5 minutes and we'll get back in the saddle.
It's still open for one for Friday, did it get available? It's open to the 14th, yeah. The one that was doing this last time? That's what I forgot. That's what we're gonna do. It's usually Sunday, like the early ones. Yeah, they usually do Sunday, but this is the 14th. No, it's probably fun. Right. I remember it. The morning. Yeah. It's very amazing. Every single time I do anything with these students, it's so much fun. Just great being around. That's amazing. Yeah. That's funny. Yeah.
She's a writer, she wants to be a writer.
So I think if we should be doing now, a lot of people really know about it, so.
They want it now. People do something, everything. Yeah, and they're good, too.
There's a whole bunch of like, US soccer has a lot of leaders like flying soccer.
Yeah, they have a ball that beats or something like that.
So it's actually playing like indoor sport, it was recorded, and like, I think there's people on the sidelines telling you like where kind of go and stuff like that. I don't know like a lot about it, but part of it was like I'm a part of like a group called the Mountain Drive, and it's like where like the member at each team is like representing their teams. Like I'm from like the best team, and like we're pretty much like kind of raise awareness about it, and we're like kind of also learning about like other disability sports or disability soccer. So it's really cool. Like I never really heard a lot about any of them, but there's a lot of them. Yeah. Yeah, it's really cool. Like I always like you all like with a disability, like seeing that so much of like like well what can you do like stop it, like like you feel amazing that they put the opportunity. Yeah. Bro.
Very good. It's time to resume. Things you should know about potassium levels with respect to the ECG. So a low potassium will tend to split the T wave. Now, in this picture, it says that you get this really prominent U wave. It's actually not uncommon for the U wave to be the same height as the T wave. So my, again, really dumb mnemonic is that the T wave kind of looks like this, which to me, that's how I draw birds. So for hypokalemia, it's watch the birdie. Watch the birdie. If you see a birdie at the T wave, you've got hypokalemia. You'll see it in all the leads in a 12 lead EKG. All the T waves will be split. Hyperkalemia causes a tidal T wave. So the T wave, as you can see, it's really, really tall, and it occurs essentially in all the leads. So tidal T wave, that is the hyperkalemia. The potassium-sparing diuretics will cause hyperkalemia because they spare potassium. So they raise potassium levels. The loop and thiazide diuretics cause hypokalemia. Hypokalemia. Potassium-sparing diuretics cause hyperkalemia. And with hyperkalemia, you get chest pain, weakness, paralysis, rapid, sometimes slow heart rates, sometimes really slow heart rates, nausea and diarrhea. And let's see, yeah. A hyperkalemia, the patient's weak and just kind of feels sick, particularly in their stomach. But you can see that you have a prolonged QR wave. The P wave is kind of wimpy looking. But the biggie essentially is that change in the T wave. That's the bit you're going to really see, the biphasic T wave. Whereas hyperkalemia caused by potassium sparing diuretics, you get the tidal T wave. Tidal T wave. The diuretics, what are they good for? They're quite good for isolated systolic hypertension that you tend to see, particularly in older chaps. They're very good for heart failure, particularly systolic heart failure, but diastolic too. Thiazides, because they preserve calcium, tend to be used in people with osteoporosis. They are to be used with caution in people with renal insufficiency. There are some drugs that are better than others in people with renal insufficiency. Not to be used at all in gout because they raise uric acid levels, and to be used really with a whole lot of caution in diabetics if you use them at all, because they can raise blood sugar and things like that. So they're useful in congestive heart failure, people with isolated systolic hypertension. As a group, African Americans respond remarkably well to diuretics. That's important because they don't respond terribly well to other groups of antihypertensive, but they respond really well to this group of drugs. Diuretics also play nicely with other antihypertensives. You can combine other antihypertensives to lower blood pressure, but the efficacy of these drugs drops if the renal function starts to go south. That's something to really keep in mind. Any questions about diuretics? All right, pair up again. You have a patient who's going to have surgery and they have bad edema, they need to get rid of it. So they were prescribed furosemide. One of you, again, the one whose last name is closer to Z, closest to Z, you are going to be the one giving the spleo. You're going to talk about furosemide, pair up, go.
Yeah, that's me. I got there. What's the date for the
Furosemide, Lasix. Furosemide is also called Lasix.
Yeah, so you're gonna be exploring a lot.
Okay, switch.
Okay, so you have some years we're gonna. Well, we're gonna try to which last 6 hours. Because it's a diuretic. It's really, and you're going to wanna watch. Seems fair. Okay, great, okay, so you're gonna wanna increase your potassium, so the avocados,
Okay, stop. Some of you are just starting to get more fluent with this. This is cool. Don't be shy. Don't be shy about this. The patient is looking to you. You're the expert. They're looking to you for information. They're also looking to you for reassurance. And so if you reassure them, number one, by being well informed, number two, by telling them, you know, you got this, you can do this. No, you don't really need to wean off diuretics quite so much. So they're not like beta blockers. So now we come to the ACE inhibitors and the angiotensin II receptor blockers. Angiotensin 1 is converted to angiotensin 2 by a capillary surface enzyme called angiotensin converting enzyme. This enzyme tends to be concentrated in the capillary beds of the lung. It's found in other places too, but the place where it's really concentrated is in the lungs. ACE inhibitors are irreversible inhibitors of that enzyme. So now the capillary cells, the endothelial cells, need to remake it and reinsert it into their apical surfaces after you dose the drug. Angiotensin II receptor blockers bind to the AT2 receptor that angiotensin II binds, and they antagonize it, they gum it up, thereby preventing the activity of angiotensin II. Remember, angiotensin II is a potent vasodilator. So these will tend to cause vasodilation. The beauty of ACE inhibitors is that they cause vasodilation without reflex tachycardia. Many vasodilators will cause your heart to beat really fast. These do not. They don't cause reflex tachycardia. They're very well tolerated. That's why these drugs are probably among the #1 antihypertensives that are used. And if any of you work in retirement homes, I'm sure you've seen a lot of ACE inhibitors being given out. ACE inhibitors. All ACE inhibitors end with PRIL, pril. If a drug ends in pril, it's an ACE inhibitor. Enalapril, captopril, quinapril, condisopril, blah, 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 blah. Those are all ACE inhibitors. The angiotensin II receptor blockers all end in sartan, S-A-R-T-A-N, sartan. So condisartan, telmisartan, irbesartan. All of those are angiotensin II receptor blockers. So the angiotensin II receptor blockers, the ARBs, they prevent angiotensin II from working. you still generate angiotensin II, but the angiotensin II doesn't work, thereby lowering blood pressure. The ACE inhibitors prevent the production of angiotensin II, and thereby lowering blood pressure. Now, the other thing ACE inhibitors do is that it turns out angiotensin converting enzyme also degrades another endogenous vasodilator called bradykinin. Bradykinin. So angiotensin II is not made, bradykinin is not degraded. Therefore, you get kind of a twofer when it comes to the ACE inhibitors, so they can drop blood pressure substantially in many cases. And this is simply to show you how these drugs lower blood pressure, because they inhibit the renin, aldosterone, angiotensin II signaling pathway, all of which comes together to increase sodium concentration inside the blood, to increase blood volume, to vasoconstrict. All of those are done away with, and you lower blood pressure. And here are those drugs. These are on page 6 and 7 of your handout. Pages 6 and 7. So notice ACE inhibitors again: pril, captopril, enalapril, lisinopril, lisinopril, benzapril, moexapril, peridinopril, quinapril, ramipril, trondopril, pril. Angiotensin II receptor blockers and sartan. Losartan, irbesartan, candesartan, eprosartan, telmisartan, valsartan, olmesartan, azilsartan, and so on and so forth. Captopril is worth mentioning because it has sulfur in it. You cannot give that drug to someone with a sulfur allergy. Captopril is a short-acting ACE inhibitor that has to be dosed more than once a day. Now, these drugs can be taken with or without food, but you must tell your patient they must be taken at the same time each day. Can anybody guess why you have to take them the same time each day? Yeah, because of the half-life. But why couldn't you take it, say, when you get up in the morning one day and then before you go to bed the next day? Why not? Yeah, you want your blood pressure, you won't have coverage because the drug is dosed so that for 24 hours you've inhibited the target. Don't take it at the same time you say there's a period of time where the target is not being inhibited. That'll cause your blood pressure to go all over the place. You want consistent relief of hypertension.
I would like a question about like the sulfur. Like, is that like a common allergy? Could you just keep mentioning it? So I want to know that.
It's common enough to where you will see it in your practice. So people will tell you, I have a sulfur allergy. So there are certain drugs with sulfur in it, you just can't give it. And pointing that out to you so that you'll make a mental note. Also, the NCLEX likes to pick on sulfur allergies sometimes. So which of the following drug, your patient has a sulfur allergy, which of the following drugs can you not give them? And I'll give you a list of drugs. So in your head, your wheels should be turning. Sulfamethoxazole, trimethoprim, the antibiotic, captopril, furosemide, formaldehyde. Those are all, drugs with sulfur in them you can't give. So ACE inhibitors vasodilate without a change in heart rate. They reduce peripheral vascular and systemic vascular resistance. They also increase diuresis. These drugs are particularly useful if you want to protect someone's kidney. For that reason, they're used a lot in diabetics. because they tend to be renal protective. They reduce blood pressure. They don't affect cardiac output. They don't change heart rate. ACE inhibitors and angiotensin receptor blockers are not to be taken during pregnancy. They're teratogenic. However, they bind serum proteins and therefore have very low secretion into milk. Having said that, babies are very susceptible to inhibition of the RAS system. So for that reason, there are certain ACE inhibitors that have been shown to be relatively safe during breastfeeding, but many pediatricians will say, let's try something else. The amount that is secreted into milk is low, is very low, but babies tend to be pretty sensitive to them. So that's the downside of those, but they're definitely not to be taken during pregnancy. Because these drugs inhibit aldosterone, hyperkalemia is a possibility. However, if your patient hydrates well enough, this is usually not an issue. This becomes an issue if you combine this with other drugs that increase serum potassium levels. And if the patient just really gets into, potassium rich foods and stuff like that, they can load up on potassium and get hyperkalemia. Typically, if they're eating normally and they're hydrating well, this is usually not a problem, but it's worth watching. And it's an easy blood draw to test, right? Easy. Send them to the lab and draw it and get a potassium level on them. Easy, easy, easy. So it's worth checking. ACE inhibitors tend to cause a dry cough. In the literature, it says it's about 20% of people. If you talk to the doctors who prescribe the drug, they'll say, that's more like 60, 70% of people. So this is pretty common. In some people, the dry cough is not a big deal. In other people, it drives them nuts. Keeps them up at night, prevents them from being able to talk. My doctor was telling me a story once. He, of course, can't use names, but he said, yeah, I had this guy, he's a lawyer, so he talks for a living. He goes to court and talks. He couldn't get through an opening statement without coughing like mad. So he came back and said, Doc, this drug is driving me nuts. I can't be on it. And he said, I changed him to something else because the cough just was too much for him to handle. Hypotension, dizziness, again, that tends to be first dose. You tend to get used to that. Headache is seen in about 4% of people. So that's not that common, and it's usually due to the vasodilation. Head-to-head studies have not really shown that these make migraines worse. Early studies tend to suggest that. More careful studies have said probably not. The big, severe side effect of these that you need to watch is this one, angioedema. Now, angioedema tends to run in families. So, your medical history, you're going to see if anyone is reacting to one of these drugs in their family. With angioedema, what seems to be the case is that bradykinin levels climb, and you have this massive vasodilation, and you get massive relocation of fluid from the blood vessels to the interstitial tissues. It starts out usually on the neck. The neck turns very red. It goes up to the face. The lips get very red and very big, and then you get swelling around the eyes. And if the patient gets any of that, it's a medical emergency. The blood pressure can drop so low they can go into shock. So they need to get to the ED ASAP if that happens. And this is much more likely to occur in African Americans than in non-African Americans. Also, African Americans have low renin levels, so these drugs tend not to work. For that reason, these drugs are not the drug of choice for African Americans. So African Americans as a group, are there exceptions? Of course there are, but as a group, tend to have low renin levels. For that reason, these drugs are not that useful. Diuretics, however, are. So ARBs have the same side effect profile, but the cough is not nearly as common. And angioedema, while it does occur, doesn't occur as often. So that's the one you need to watch with ACE inhibitors. So watch the potassium. If there's a cough, have them take cough drops. Watch for angioedema. So what are they good for? Well, drug interactions. Anytime you use a medication that also increases potassium levels, you can increase the risk of hyperkalemia. If you combine these drugs with other antihypertensives, they will have additive effects. ACE inhibitors and ARBs play well, in fact, with other medicine. Don't combine these drugs with nonsteroidal anti-inflammatory drugs because they can damage the kidney. Nonsteroidal anti-inflammatory drugs include aspirin and ibuprofen and drugs like that. You should not combine those with ACE inhibitors. So that's one interaction you really need to be aware of to warn people, take Tylenol, don't take ibuprofen or something like that. So these are particularly good for people with diabetes mellitus or proteinuria. Pretty much standard fare for folks with heart failure, systolic or diastolic heart failure. Very good post-myocardial infarction because they decrease the preload and afterload too on the heart. Renal protective in diabetics, and they seem to arrest the decline of renal function in folks with renal insufficiency. They're contraindicated in pregnancy, contraindicated in those who have hyperkalemia or those with a history of angioedema. If people have renal artery stenosis, these drugs should not be used. Now, it depends on the degree of stenosis. Several urologists have told me, depends. Depends. So that one, the provider is going to need to make that call. Pre-existing kidney dysfunction, the degree of impairment, it depends. In that case, you want to use them with a good deal of caution. Any questions about ACE inhibitors, ARBs, before we go to calcium channel blockers? Incidentally, as you have on your handout, there is a direct renin inhibitor called aliskiren. Aliskiren is a newer drug. Aliskiren has a long half-life. It's used in people who can't take ACE inhibitors or ARBs. This drug can make you very dizzy, and it can cause an upset stomach. It's not used a lot. It's really expensive. Another reason why it's not used that much, but it's a potential antihypertensive. All right, calcium channel blockers will probably only get to start this. There are two groups of calcium channel blockers, dihydropyridines and non-dihydropyridine. Dihydropyridine does not really roll off the tongue. Who names these things? So we're going to call them DHPs. How's that? Can you handle that? So DHPs and non-DHPs. So what do these do? Smooth muscle and cardiomyocytes have a voltage-gated calcium channel called an L-type. An L-type calcium channel. When depolarized, these cells will, well, these channels rather will open. Calcium enters the cell. Remember, calcium helps smooth muscle contract. Calcium channel blockers bind to L-type calcium channels and prevent them from opening. Therefore, the smooth muscle cell does not get calcium. Therefore, the smooth muscle relaxes. If it's a smooth muscle that surrounds a blood vessel, you get vasodilation. Therefore, they decrease systemic vascular resistance. The DHPs are used for blood pressure. The non-DHPs tend not to be, because they tend to work in the heart more than they work in the blood vessels. So your DHPs and your DHPs are all going to end with DIPINE. Think dipine, think two pine trees. Two pine trees. These are the two pine tree drugs. Dipine. So, amlodipine, felodipine, nicardipine, isradipine, nifedipine, nimodipine, nisolidine. Those are the DHPs. They decrease systemic vascular resistance. And here are your DHPs. Notice they're used a great deal for hypertension. The exception is this one here, nimodipine. Nimodipine is used for arachnoid, subarachnoid hemorrhages, because when you get a subarachnoid hemorrhage, the veins that are in the subarachnoid space, when they're exposed to the blood, they'll tend to spasm. That spasming can affect blood flow to the brain. Nimodipine is given intravenously to prevent that spasming. So that's what you use nimodipine for, subarachnoid hemorrhage. All the others are available as pills. Some come in IV route. You see nicardipine is given IV. The non-DHPs, there are two of them, verapamil and diltiazem. Verapamil and diltiazem. Difficult words to remember. Everybody say that with me. Verapamil, say it. Let's say diltiazem. Verapamil and diltiazem, say it. Very good. These drugs are antiarrhythmic drugs. They're class 4 antiarrhythmics, which we'll get to. So we'll talk about those when we get to the antiarrhythmics. The ones we're interested in now are the DHPs that you see on your handout. And if you didn't bring a handout with you, print them out and take a look at them. All right, we are out of time. We'll pick this up right here. We'll finish this. Then we will go to medications for lowering serum lipids. And then after that, I think we do drugs that prevent clotting and antiplatelet drugs. And then we'll look at drugs for antiarrhythmics, and then antibiotics after that, and then drugs for diabetes and other endocrine things, then the anti-cancer drugs, and then we're done. Oh, gout's in there too. Oh, you're done already? Okay, I'll take them now, sure. All right, crew, we're done. So have a safe trip back, and I will see you guys hopefully Wednesday. Happy Easter, belated, and Lord bless you all.